Hello, everyone, and welcome to McGill Cares, a webcast series supporting family and informal caregivers of people living with dementia. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret, Professor of Medicine from the Division of Geriatric Medicine, and Dr. Serge Gauthier, Professor Emeritus in the Departments of Neurology and Psychiatry. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill Dementia Education Program offers a comprehensive range of free multilingual resources to educate and support people who are living with dementia, their families and caregivers, and healthcare professionals and medical students. We invite you to visit our website at mcgill.ca/dementia to learn more about our program. So today we are going to be talking about early prevention strategies, research, and treatment of Alzheimer's disease. And I'm very glad to have as my guest Dr. Simon Ducharme, who is a neuropsychiatrist and a clinician-scientist at the Douglas Mental Health University Institute and the Neuro. He specializes in frontotemporal dementia and the interface between psychiatric disorders and dementia. He conducts research on novel dementia biomarkers and clinical trials, including gene therapies in frontotemporal dementia. Dr. Ducharme holds a Senior Clinician Scientist Award from the Fonds de Recherche du Québec and is the author of over 180 scientific articles and 8 book chapters. He's a director of the McGill Division of Geriatric Psychiatry and Neuropsychiatry and the Associate Chair of Research for the Department of Psychiatry at McGill. He is also a fellow of the American Neuropsychiatric Association. So during today's webinar, Dr. Ducharme will explore practical strategies that may help lower the risk of developing Alzheimer's disease, including lifestyle habits and other evidence-based prevention approaches. He will also discuss the current treatment options, especially those ones that have been just approved by Health Canada, the recent progress in Alzheimer's research, and a very unique opportunity to participate in a study for individuals who may be at risk for the disease. Welcome, Dr. Ducharme.
Thank you, Claire. Thank you for the invitation and for the opportunity to meet with everyone online. We last spoke in February about dementia treatments, and a lot has changed over the last few months, so I'll be happy to go over that. And as you mentioned, for people online, at the end, I will present the next frontier in research in Alzheimer's prevention and give some information about potential participation for people who could be interested by this opportunity. Today, we will talk about early prevention strategies, current research, and new Alzheimer's treatments. We will cover that in about 30 minutes. So we'll really focus on what are key new developments for patients and families. These are my conflicts of interest. So I do work in dementia clinical trials with various companies, including the companies that have developed the recently approved treatments for amyloid removal in Canada. We start with a very important information about Alzheimer's disease. So in practice, we think about Alzheimer's disease as the cognitive decline and loss of autonomy phase. So this is the phase that we used to call dementia, we now call major neurocognitive disorder. But this is the end stage of the disease. Biologically, it is now very clear that the brain changes associated with Alzheimer's disease, amyloid and also tau, start many, many years before the onset of cognitive decline. So if we look on the left at the black curve, this is the amyloid accumulation. And this will occur 10, 15, 20 years before people start to have common symptoms like short-term memory decline. So this is what we now refer to as the preclinical phase of Alzheimer's disease. So this means I have brain changes of Alzheimer's, but no symptoms yet. As we progress, we start accumulating tau and having volume loss. And this is when you start to have symptoms like early loss of short-term memory, word searching, some difficulty with spatial orientation. When it is the early phase of that and the person remains mostly independent, functional, we call that mild cognitive impairment. And when you start to lose autonomy, so when you pass the second gray line, this is the major neurocognitive disorder stage. And this is really where the person will need an increasing amount of help to accomplish daily functions. We know this information because of biomarkers. So biomarkers are various types of tests that allow us to look at what's happening in the brain in terms of amyloid, in terms of tau, in terms of brain shrinking that we call atrophy. So we have been able to do that for many years now with forms of PET scans or lumbar puncture. The major development over the last year is that we can now also do this with blood tests, in particular a test called p-tau217, which is a protein we can measure in the blood, and that very highly correlates with the presence of amyloid plaques in the brain. So in clinical practice, this is now a test we can use to confirm the presence of Alzheimer's pathology in someone with symptoms. But all of these biomarkers can also be used increasingly to detect biological features of Alzheimer's before even symptoms appear. So the whole goal of our work is to minimize the burden of Alzheimer's dementia and related diseases. So the optimal way to do that is to prevent it. Now, the common discourse that you probably have been hearing is that dementia is increasing. This is true in some ways. It is true because we still have growing population and an aging population. So given that dementia is highly associated with increasing age, the total number of people with dementia is increasing. However, there is a hidden good news in all of this, which is that the actual individual risk of dementia has gone down. So mostly because of better health management and cardiovascular treatment. So treating things like high blood pressure, diabetes, cholesterol, less smoking. The risk per population is going down. And there are even some figures showing that it could be reduced by up to 40% compared to 40, 50 years ago. So there are some actions that can be taken to reduce the risk at the individual level. There are multiple risks that are considered modifiable. So of course, part of Alzheimer's disease is aging and the genetic risk. This cannot be changed. However, there are a number of risk factors that are potentially treatable, modifiable. Some of them are more at the societal level, like increasing education, but a lot of them are actually individual risk factors that someone can potentially improve to reduce their own risk of dementia. A lot of them are related to vascular disease, obesity, high blood pressure, smoking, diabetes. These are all risk factors for small strokes, which can favorize the appearance of amyloid and Alzheimer's disease. But if you look at the figure on the right, you might be seeing some risk factors that are less well known. For example, you see that we have hearing loss, which accounts for a very significant proportion of the risk, social isolation, and even visual loss. So there's a medical part to prevention, measuring blood pressure, treating diabetes, cholesterol, but there are also actions that people can take individually, increasing their physical activity, but also things like increasing social connection, social interactions, and screening for sensory loss. So making sure as soon as there are signs of slight loss of hearing to be tested by an audiologist and correct those sensory loss. So not wait for them to be extremely severe before intervening. So this leads to our prevention mechanism. So they address those risk factors. So some of them can be at the level of cognitive reserves, so higher social interactions, more education, preserving hearing and vision because this is cognitively stimulating. Some of them are at the level more of inflammation. So everything that relates to diet, diet like the Mediterranean diet that are oriented toward fresh produce, fruits and vegetables, reducing refined sugar. And then factors that are related to vascular disease, oxidative stress, so improving weight management, stopping to smoke, treating cholesterol. So individuals' risk will vary depending on their own genetic risk, their age, but also these factors. And so people who really want to reduce their risk of having dementia can look at those risk factors and identify potential targets of improvement in their own personal life. Now, if we cannot prevent, we now have opportunities to intervene to try to treat Alzheimer's disease in its earliest form. So these are the new anti-amyloid therapies. So I will present to you the two new medications that have been approved by Health Canada. When we spoke in February, there was only one, there was lecanemab. A second one has been approved a few weeks ago, donanemab. So we will review what can we expect from those medications? What are the risks? Who is it for? Who is it not for? So these two medications are what we call disease-modifying treatments. So on the left, you see a depiction of what we currently have with the Nepizil, rivastigmine, and others in this class. The idea is to improve a little bit symptoms, but we're not changing the progressive course of the illness. And these are medications that were usually studied over a few weeks, a few months. What we now are starting to see emerging with lecanemab and donanemab are medications that alter the rate of progression. So these are disease-modifying treatments because over time, the differences between the natural progression in Black and the progression when you're on treatment, because there's a slowing of the progression, we can see that over time, the benefits increase more and more. The two treatments that have been approved by Health Canada target amyloid plaques. So amyloid plaques is a core feature of Alzheimer's disease. It is the earliest change that we can see in the brain. People who have genetic mutation where they accumulate more amyloids have very young forms of Alzheimer's disease. So amyloid is a key factor. However, Alzheimer's is also a complex disease with many other components: tau, cholinergic function, inflammation, mitochondrial function. So obviously, to completely resolve Alzheimer's, you need to be able to address all of that. So an amyloid treatment only addresses part of it, but it is a very significant proportion, and it is potentially a building block to add different types of interventions over time. So I mentioned that we have two medications. You have lecanemab, which is commercialized under the name Leqembi, and donanemab, which is commercialized under the name Kinsula. They both target amyloid through slightly different mechanism. So lecanemab targets the small forms of amyloid. So small accumulation, you see in the figure, protofibril, fibril oligomers that are still circulating in the cerebrospinal fluid, and they help to remove them. And they also remove the amyloid that is part of the plaques. Whereas donanemab really targets those plaques. So they both remove a significant proportion of the amyloid, but through slightly different mechanism, which is related also to their the way they're prescribed. So lecanemab is every 2 weeks. It's an infusion through the vein. It is meant to be an ongoing treatment up until someone reaches the moderate disease stage. Whereas donanemab, which is also an infusion through the veins, is given once per month for a period of a maximum of 18 months. So it is a time-limited treatment. These medications were approved based on very large studies. which had thousands of people. Clarity was the name of the study on lecanemab. Trailblazer is the one for donanemab. The major points, so these studies are conducted over a year and a half, and this is the randomized phase. So that's when some people get the placebo, the false medication, some people get the active drug. These were patients between 50 and 90 years with MMSE, and that's the general cognitive score we use of 22 and above. So it's very important to understand that these are patients who are very mild into their disease. So they have memory loss, they have biological proof of Alzheimer's, but their functional impairment is either there's no functional impairment, they can live independently, or it's mild. They're starting to have a bit of difficulty with finances, taxes, errands, but they take care of everything else and they are able to stay alone for a prolonged period. So this is early stage Alzheimer's disease. What we've learned from these clinical studies is that these two medications remove amyloid. So if we do a PET scan for amyloid before and after, we show that the burden of amyloid goes down very, very significantly, to the point that if you were to do an amyloid PET scan to someone that has been treated, they might come up as negative for Alzheimer's disease. This leads to a reduction in the rate of progression. So very important concept. You are still progressing on those medication, but you're not progressing as fast. And the average figure is about 30%. So 33%, about a third slower in terms of progression. And what's very interesting is that this is seen both in global measure of severity, in measures of cognition, things like memory or language, in independence, so the activities of daily living. We see the same reduction of progression in quality of life measures, and even more impressively in care partner burden. So all the signals are in the direction that people who are treated, the well-selected patients who are treated, will not progress as fast and will have less deterioration of their function, cognition, quality of life, and will be less of a burden on their care partners. Then this is the 18-month study, but people were continued to be treated in the extension study for up to 4 years. And the key finding from that is that when we compare these treated patients to historical controls from a very well validated study called ANI, we see that if you look at the orange curve, the difference between treated patient in orange and this light blue curve, which are untreated patient, gets bigger and bigger and bigger over time. So this is really showing the disease modifying property of the medication. And this is very important because when we look at the difference at 18 months, it is not that big in absolute difference. However, we see that over time, the difference gets more and more impressive. And so this translates, if we look at the risk of progression to the next stage, which is moderate dementia. So here we're treating very mild patient. We want to see what's their risk of reaching moderate dementia. And moderate dementia is when you start losing autonomy for more basic things, dressing yourself, washing yourself, eating. So this is usually the stage where the quality of life goes down significantly. So we want to push that back as much as possible. And so patients treated with lecanemab cut their risk of progression to the moderate or severe dementia stage by more than 50%. So they're still progressing, but we're essentially trying to buy time of higher quality of life in the mild cognitive impairment stage. Another way to look at this is that over 4 years, you're saving about a year. So if you take the medication for a year, it's as if your disease, on average, has evolved for 3 years only instead of 4. So this was lecanemab. We now have donanemab, a second medication in the same category. Some differences in the way it's prescribed. It's given every month instead of every 2 weeks. It's only for 18 months as opposed to continued treatment. But overall, when we compare the two pivotal studies, the results are quite similar. So again, we're seeing this slowing of progression. The differences increases over time. We have up to 3 years with donanemab, and the magnitude of the difference is fairly similar to what I presented for lecanemab. And again, with donanemab, we're seeing that we're reducing the risk of progression to the next stage. So here, this is a more conservative measure where we're looking at progression to next stage, including from MCI to mild dementia. And we're reducing that risk of progression by about 30%. So again, you're seeing that number of 30% coming back. Now, these are not medications that are without risk. If you've read a bit about those medications, you know that they are associated with an increasing risk of brain edema, which we call the ARIA-E, and small bleeds, ARIA-H, for microhemorrhages. It's very important to know that these are reactions that can be seen in patients with Alzheimer's disease, even without treatment. So amyloid goes in the blood, and that's making them more fragile, and you can get these reactions. So these are not unknown phenomenon for Alzheimer's, but particularly the edema risk increases significantly for patients who get amyloid removed through one of these medications. Now, is this a source of concern? It is something that needs to be closely followed. However, in practice, it is very manageable. So we look at lecanemab, for example. So if we select patients carefully, the risk of having an ARIA at all is about 20%. If you look at the placebo, it's almost 10%. So part of that are not related to the drug, but let's look at 20%. Most of these patients would not have known they have a reaction like this if they had not been followed with a brain MRI. So, I mean, in other ways, they have no symptoms and it clears on its own. So we're interested clinically in people who have symptoms from ARIA. This is 3%. And if we look at patients with more serious symptoms, so symptoms that are severe enough to go have an emergency room visit and then can go all the way up to stroke like events, this is 0.7%. So we're below 1%. So this is the trade-off, a 30% reduction in speed of progression, 0.7% of risk of a more significant adverse event. This is why in practice we have very stringent follow-up with regular brain scans. Most of these events will occur in the first 6 months. So that's really when we're super vigilant. We have scans every few weeks and we monitor patients very closely. Once you've passed the 6 months mark, then you're usually okay to continue for a longer time. The rate of new ARIA after 6 months is small. So who is it for? Who is it not for? So it is for patients with biological Alzheimer's disease in the very early stage. So either mild cognitive impairment, so people who remain functional, people who are just entering the phase where they start losing a bit of autonomy. The MMSE should be 22 or above. We need to have the proof that they have amyloid through blood, lumbar puncture, brain scans. And these are complicated treatments. They require infusion in infusion centers every few weeks, regular MRIs. So you need to have good social support to make sure you go to all appointments, that you are in liaison with the treating team. There are contraindications. We need to make sure before treatment that we do a brain MRI to make sure there's not too many small bleeds already. That would be a risk. We check for a genetic risk called ApoE, and patients who are at the highest genetic risk, E4, should not be prescribed this medication because it is associated with a higher risk of complications. One should not be taking blood thinners, anticoagulants, other than small dose aspirin, and they should be generally in good medical health. So this is not a treatment for more advanced stages of dementia. It is not a treatment for older age mixed form of dementia with a lot of vascular disease or Lewy body. It is really for isolated early stage Alzheimer's disease. Now, you might have heard that these medications are not currently covered by the governmental plan. This comes from a negative decision from INES in December. They looked at this data very conservatively. They mostly look at the data at 18 months. And they considered that the difference in absolute was not large enough for their interpretation. They did not factor, don't give much weight to the longer term data that I showed you, that the difference kept getting larger over time. They really looked at the randomized placebo-controlled phase and considered there was not enough benefit. And so they did not look at cost efficiency, and they do not cover it. So currently, it goes back to private insurers and patient access program. But is mostly in the private market. So obviously some inequities there. Those treatments are around $40,000 per year. Price will depend on which pharmacy, weight of the patient. So these are costly treatments. Now, what is the next frontier? So these are treatments for the mild cognitive impairment stage. So just after this gray line. What we want to do is to be able to treat before that. So identify patients who have amyloid in their brain through PET scan, lumbar puncture, blood tests, and see if we give them a treatment to remove amyloid, can we push back the loss of memory and the cognitive decline? So trying to treat Alzheimer's at the pre-symptomatic stage to delay cognitive decline. And so this leads us to the research that I wanted to present. So there will be a clinical study called Preventron with a large pharmaceutical company called Roche that will try to do that with their medication called trontinemab, which removes amyloid and has lower risk of ARIA potentially than some of these approved drugs. So we are looking for people who are worried about their risk of having Alzheimer's disease in the future. So this is not a study for people who have been diagnosed with Alzheimer's disease. This is for healthy people who are concerned that they could develop Alzheimer's disease. So you have to be between 55 and 80 years of age. You do not need to have a family history of Alzheimer's disease, but your odds of having amyloid are higher if you do. So that could be a reason why someone would want to participate. And so the process will be to do a simple blood screen. So interested participants can learn about the research, sign a consent, get tested with a simple blood test to know if they have high levels of the p-tau217, which screens for amyloid. So if it is normal, then you will be told that you do not have amyloid, and this will be the end of it for you. If you do unfortunately have high amyloid through the blood screen, then you will go to the next phase of the study, which would be a PET scan to confirm you do have amyloid for 100% certainty. And then you could receive the treatment for many years to hope to prevent the decline of memory. So if some people who are listening want to know more, you have the QR code that you can scan and respond to a brief survey to send your contact information. You also alternatively can contact the research clinic. So this will be done under my direction at a clinic called GP Research, which is right in front of the MUHC Hospital Glen. You have the email on the slide, you have the phone number, you have the website. And so if you want to know more, feel free to reach out through the QR code, email, or phone. We will be starting to do the screenings through the blood in July. And thank you for your attention. And I hope that everyone was able to learn something. And thank you.
Thank you very much, Simon, for this incredibly informative presentation. I think that was probably one of the most thorough and comprehensive presentations that I've had to really understand this, like what is going on with the latest drugs. I have just one question for you. For those people that want to participate in the clinical trial, we get a lot of emails asking us if we could refer people for, so there are some people they want to find out if they're genetically at risk.
Yeah.
So for those people that are going to register for the clinical trial, would you be able to determine if they're carrying the ApoE4, for example?
So the ApoE4 will not be tested as part of the blood screen initially. It will be tested for people who are positive, who go in the next round of the research. For pure ApoE detection, we do not necessarily recommend to do that medically because it is not associated with different interventions. It is something that can be discussed with physicians. We do that at the Douglas Memory Clinic in our prevention arm, but after careful discussion with physicians. So in this study, people would know if their blood screen for amyloid is positive or negative, but they would not be informed of their ApoE genotype through research.
Okay, and I'm assuming obviously that the people that are going to be participating in this clinical trial, it will be done through very safe measures and in a clinic or hospital-like setting so that
Yes,
people could feel reassured and having you overseeing this whole trial. I mean,
absolutely. And
how,
very,
how
very close supervision and very close oversight by myself and a team of nurses and other doctors.
Okay, well, thank you very much for taking the time to be with us today. And I hope that, for those people that would like to have some hope and know that there's research going out there, it would be really amazing if they could participate in your trial. So thank you very much.
Thank you, Claire.
So this webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a donation or have more information about our program, please visit our website at mcgill.ca/dementia. Thank you for watching.